Hi everyone, we are back with a short talk about some obstructive respiratory disorders. So remember, to obstruct means to block or make difficult. Like if somebody is obstructing traffic, they're blocking it in some way, they're making it difficult. So that's different than a physical, mechanical obstruction where somebody might inhale a peanut or a marble or a grape, and that causes an obstruction. So these type of obstructive disorders are going to involve some sort of changes to the anatomical structures of the respiratory tract, which impede airflow. So we'll start with disorders that are discussed in a lecture that's also posted to YouTube called Plural disorders and Parenchymal disorders. This is a combination of two specific respiratory disorders, which involve chronic bronchitis and emphysema. If a patient has both of these anatomic derangements that we see in chronic bronchitis and emphysema, so they're exhibiting both of these disorders, they are put into a category, which we'll use as more of an umbrella term for someone with both disorders. Their disorder is now chronic obstructive pulmonary disease, or COPD. So again, COPD is a combination then of chronic bronchitis and emphysema. So we have to then remember what the main anatomical derangements are in chronic bronchitis and emphysema. So if you remember, in chronic bronchitis, the main problem is going to be physical changes to the epithelial tissue of the bronchi. And because it's called bronchitis, we know that it's inflammation of the bronchi. And we also know that over time we get metaplasia of the tissues, specifically that epithelial tissue, which should contain these squamous epithelial cells intermixed with goblet cells meant to make mucus, right? And in order for that mucus to move, it needs the cilia to move that mucus. Remember, in this metaplasia, we lose those ciliated cell types. The cells instead change to have a thicker lining to protect the innermost tissue, but we lose the cilia and increase the number of goblet cells. So that's going to lead to a lot of coughing and then changes to the smooth muscle in the bronchioles and the bronchi. We're using them more, so therefore they're going to become larger. They're going to become thicker and stronger. Whereas we see the common derangement in emphysema is going to be abnormalities with the alveoli themselves. The alveoli become collapsed, which makes breathing or ventilation very difficult. So if one person doesn't have, one or the other, so if they're not truly just suffering from emphysema or truly just suffering from chronic bronchitis, we'll call it COPD. There are common signs and symptoms you'll see in COPD, regardless of which type. Those involve dyspnea or air hunger, shortness of breath, exercise intolerance, which is a reflection of the inability of the heart rate to make reflexive changes to accommodate exercise. So it needs to go from pumping 5 liters of blood a minute to 25 liters of blood a minute. So there has to be a really healthy heart tissue and good lung tissue. So it's difficult for that to happen in COPD. One commonality seems to be a history of heavy smoking, which changes the lining of the bronchi and bronchioles in a specific way, which is commonly associated with that metaplasia. chronic cough, because of that lack of ciliated cells, the individuals need to engage in their own clearance. They have to move their own mucus. So there's chronic cough. And in North America itself, there is a high incidence of COPD, even though this isn't necessarily the area where we have the highest levels of smoking in the world. There's other things that can associate with as well. Okay, there are two recognized types of COPD, and they are going to tell you essentially which disorder is dominant. So remember, it's emphysema and bronchitis, but one of them might be a little bit more easily observable in a patient. In type A, the dominant derangement is emphysema. So in emphysema, remember, the main issue is going to be alveoli that become collapsed. They become merged together, which decreases the surface area for gas exchange. That means the individual is going to utilize quite a bit of energy in order to undergo ventilation. So that means emphysema in general favors weight loss. So these patients appear thin and gaunt, generally male. This W loss is weight loss. They tend to lose weight because emphysema breathing requires a lot of energy. When you do some blood gas testing, we can see normal levels of peripheral or pressures of CO2 and O2. You can hear an expiratory wheeze, which is also something you'll see with asthma that lets you know that there is a restriction in the bronchial tissue. Normal hematocrit. Hematocrit is if you took a sample of blood and spun it down so that it's separated out by weight, the hard-packed red blood cells at the center, that's the hematocrit. So the hematocrit appears normal. Mild pulmonary hypertension. Pulmonary hypertension refers to physiologic changes to vessel tension within the lungs. When you have these changes to the lung vessels, which are typically the most compliant vessels in the body, that changes almost the entire physiology of blood flow through the lungs itself. When the pressure goes way up in the lungs, in the lung vessels, there is a tension that tends to force out fluid. And when you see this happening, the fluid will leak out into the lung tissue, which can be pretty pronounced, and that's referred to as pulmonary edema. Okay, another thing that's characteristic of type A is hyperinflation of lungs, because we see this general breakdown of the integrity of tissue in emphysema due to chronic hyperinflation, and that leads to almost a hyperelasticity of the tissues. So when there is this chronic hyperinflation or overinflation of the lungs that essentially utilizes the high amount of elastin in the chest wall to be able to stretch bigger and stretch further to accommodate greater filling of the lungs. The tissues of the chest wall can change over time, and in the barrel chest, which you see up here in this animation, we see not only does the sternum and the associated ribs move out, but remember the ribs go all the way back to the vertebra. So we see these chest wall changes to accommodate hyperinflation of the lungs, which is prevalent in, again, type A and characteristic of hyperinflation of emphysema. Okay, type B, the B there should remind you that it's bronchitis dominant, so chronic bronchitis. And bronchitis in general is favoring weight gain, so these patients tend to be overweight as opposed to our very thin, gaunt type A patients. There will be dyspnea, so shortness of breath with rapid breathing. A productive cough, which is characteristic of chronic bronchitis. Lots of sputum because they're bringing it up. It's not going through the mucociliary tree down to the esophagus and stomach to be digested because that cilia has changed. Now the cough and the clearance that that patient engages in is going to move the mucus out through the mouth, and then it'll be sputum. Because there is hypertension in general, you see not only pulmonary hypertension, but also systemic hypertension. You see fluid being forced out of vessels all throughout the body. And when that happens, we call it systemic edema. Remember, when mucus is moving, it's fine, but when it does start to stagnate, that's when it picks up more disadvantageous bacteria, and you can see chronic infections. There is more hypoxia, so low oxygen levels in the blood, more cyanosis, so inadequately oxygenated hemoglobin, which can present as a bluish hue, bluish tint to the skin, not screen. I'm looking at a screen. All right, and then increased hematocrit. So that tells you that there has been some sort of message to the body that there's not enough oxygen. Just as a little note, there's things around the kidneys called JG cells, and it's their job to sense how much oxygen is in the blood that's entering the renal areas. If the JG cells get a signal essentially that there's hypoxia, that there needs to be more oxygen coming in, it makes some alterations in the body, so it can also trigger the angiotensin system. But another thing that we see is the activation then of EPO, erythropoietin. So EPO is another thing. It's actually made by the kidneys, and it stimulates red blood cell production by the bone marrow. So whenever you see increased hematocrit, it means that there was general hypoxia sensed by the kidneys, and then the production of EPO, which makes more red blood cells. All right. As we mentioned before, not only do we have systemic edema due to general hypertension, but also pulmonary hypertension. Again, that means that there's tension or high pressure of the blood vessels, like the skinny jeans theory of blood vessels. There's only so much room for fluid to go. There's only so much that can fit in. And remember, capillaries are leaky, so if the fluid stretches the walls of the capillary, we are going to have to fit in the elements of the blood and keep those inside of the vessels. So components of the plasma will start to leak out and then land in the lungs. We call that pulmonary edema. And all of these changes to the lungs and their tissues can definitely stress the heart. And right heart failure is associated with pulmonary disorder. It's also called cor pulmonale. There's a U here. Cor pulmonale. It means with the lungs, literally. So right heart failure could be something that's either a risk factor in COPD-B or something that's already present. So A, emphysema, B, bronchitis. These are some pictures of patients that have been categorized as type A and type B. So we can see the emphysema dominant, the very thin, gaunt male. Because of their hyperinflation, their interesting respiratory rate that goes along with that, that leads to almost this hyperoxygenation at some points. And that can lead to, or has led to, the name of a pink puffer to describe the type A COPD patient, whereas type B is used, a mnemonic used to remember what it is the blue bloater. Again, B for bronchitis, the patients are a little bit heavier. They have more symptoms of cyanosis, systemic edema, pulmonary hypertension. So obviously these are just mnemonics to help you remember what the different types are, and they're not things that you would call or refer to anybody as, just a mnemonic. All right, so because COPD is two things combined, essentially, we've got our bronchitis plus the emphysema, we're going to see a whole bunch of changes associated with this. So three things that we'll see all the time. So inflammation and narrowing of terminal bronchioles. And if you remember the anatomy, the terminal bronchioles are another name for non-respiratory bronchioles, so bronchioles that are not associated with alveoli. Dilation of pulmonary spaces. Because gas diffusion is less efficient and airflow is altered in some way and coughing occurs, we're going to see dilation of different tissues that are very compliant and high in elastin, but this will definitely make gas diffusion less efficient. So if we think of the alveoli, which should look like a group of grapes separated by septi, in emphysema, those septi break down, and now we just have a collapsed sac of alveoli. So we've lost a ton of that surface area, which makes gas diffusion less efficient. Over time, the elastic recoil properties of the lungs are definitely affected. We can see changes, again, mainly if it's emphysema dominant. There's hyperelasticity. That's actually what you see in this curve. If we're doing a vital capacity test and we're asking the patient to blow out all of their air, we're seeing this curve like this. So it's a very high, it's a very fast, and a very quick removal of air from the lungs. But just like stretching out a rubber band over and over again, you might stretch it out every day and it snaps back really nicely, but over time it gets really stretched out and then it starts to lose some of its snap. So over time we start to see that type of change, which leads to a general loss of elasticity. Okay, so going back up here, with the inflammation, we see the swelling of the bronchial mucosa, so it becomes hypertrophic. We see increased bronchial secretions because mucus production goes up when there is bacteria there, when we're not feeling well. Increased resistance to airflow because of the hypertrophy of the epithelial tissue and also the smooth muscle. And then the vessel changes within the lungs. It's going to be difficult to get airflow and then also gas exchange. We also see a general problem where air enters too quickly into the lungs because there is some component of emphysema here. We do have this hyperinflation. So three anatomic derangements. We have the inflammation and narrowing of the terminal bronchioles, dilation of pulmonary spaces, and loss of elasticity. All right, so what are you going to do about it? How do we treat COPD? Well, the first thing, if we go up here, those are just listings of things, but if we use a little treatment protocol. So first step, we want to do some sort of patient education and self-management. So we know that a lot of this is associated with smoking. So giving some smoking cessation, educational information, supporting them with agonist-based therapy like nicotine replacement, or using something like a Chantix medication to treat the craving for nicotine at its source. Not everybody's able to quit smoking though, so maybe they're not going to do that, but we can always start there. Then you might want to move on to bronchodilators. Bronchodilators, specifically Beta2 agonists, which are going to target in the smooth muscle of the bronchioles, these Beta2 receptors. The number 2 is there. It's an even number, which means it's an inhibitory receptor. So when a drug or any kind of substance, like norepinephrine even, or epinephrine, binds to and stimulates a Beta2 receptor, we get an inhibitory action. This is muscle, and we know that the action of muscle is to contract, right? So instead of seeing contraction, this beta-2, this inhibitory receptor, it drives that to be blocked. It inhibits that. So we get relaxation and then dilation instead of contraction. Inhaled corticosteroids. So these are a nice prophylactic therapy to reducing the need for bronchodilators. Well, I said bronchodilators. Not only can we use beta-2 agonists, but another compound you'll see used in COPD is theophylline, which is actually in the caffeine family. It's a pretty potent vasodilator. It's not the safest one, but it works to kind of reset the vagal tone of the bronchi and can be used in those situations. All right, but anyways, inhaled corticosteroids, those are inhaled substances. Any kind of corticosteroid is going to lead to reduced inflammation in any tissue where you put it. But when they're inhaled, they're going to specifically be targeting their action to the lungs, to the bronchial tissue. And the more you give inhaled corticosteroids, which are taken daily, the less we find that patients have to use their rescue drugs. Antibiotics are a good thing because we have recurrent pulmonary infections with COPD. So giving antibiotics as infections occur, not all of the time, hopefully, because you get a lot of resistance and downstream changes due to antibiotics. And then possible suctioning or draining of secretions. Oxygen therapy, that needs to be added after a little bit to supplement especially when there is shortness of breath at rest. That's when we'll have to have definite supplementation. And then finally, diuretics, which just encourage diuresis or water loss, / vasodilators like nitric oxide, things of that nature, to treat or prevent right heart failure. So the worse it gets, the more we're going to move down this line and eventually maybe work into surgery to resect any areas that become irreversibly damaged. And just while we're on that note, we also have another obstructive disorder quickly to talk about, bronchial asthma. I'm pretty sure this is Russell Crowe right here, right after Gladiator. And he apparently has asthma. And in asthma, there is characteristic changes to the bronchioles where they become inflamed. Not only are they inflamed, they are hyper responsive, meaning that they're kind of played like accordions. They contract really strongly and then they dilate. And they do that very quickly. And it's hard for them to move slowly. We want them to move slowly in order to accommodate changes to the physiology in a better way. When something is hyper-responsive, it's also more likely to spasm. And spasming is like a muscle twitching in your eye. It doesn't stop. And when these muscles in the bronchial tissue start to spasm, they are going to impede airflow. There's also baseline inflammation. So not only do we have bronchial constriction, that is associated with chronic inflammation in these areas. So here we have a normal bronchiole, so there's epithelial tissue, there's muscle tissue in the middle. But when we look at one with asthma, we see a lot of baseline inflammation, which makes this lumen on the inside a lot thinner. There's also an increase in mucus production in asthma. So not only is there thickness, there's also mucus that needs to be moved. And asthma can be allergen mediated. A lot of it is, which means you can teach people allergen avoidance, allergy management. And there's also different things that can bring on asthmatic symptoms like cold, exercise, stress, anything that would cause that physiologic change to the space inside the bronchioles by having that smooth muscle dilate or relax or constrict. Whenever there's a move in one way, there's the possibility of a bronchospasm, which can be difficult to treat once you're there. Difficult to treat in that without the medication, it's really hard to do anything about it. All right, some things you'll see in asthma: shortness of breath, severe cough. This is not a productive cough. It's a very specific asthmatic type of barking cough. And also a wheezing exhalation is pretty characteristic of asthma. Again, the pathophysiology of this is hypertrophy. This should be of airway, smooth muscle, and the mucus glands. So the wall is going to become thicker with inflammation. There's always going to be the formation of exudate. So there will be fluid flowing out into the nearby tissues, and then edema in those areas as well. All right, so when we get this hyper-responsiveness, this bronchospasm due to either allergens, exercise, cold, heat, sickness, there is one thing that is almost always used, and that is the rescue inhaler. The treatment for asthma is on, hopefully prevention, but also on immediate resolution of the symptoms. And in that immediate resolution, we see the Beta2 inhalers used. The albuterol is the main generic that you'll see. This is given in a meter dose inhaler. It's a Beta2 drug, meaning that it binds to Beta2 receptors, inhibits muscle contraction, and allows relaxation and dilation of the bronchiole. We consider this a rescue medication. It reverses bronchospasm, meaning that it's helpful in an attack. However, you don't want patients using this a lot. There's a rule of twos. It shouldn't be used more than 2 times a week, more than twice a day, and 2 times per attack, with 2 minutes in between each puff. If patients are using it more often than that, then they have uncontrolled asthma, and you might want to add something else to their regimen. In the case of a severe attack, we don't want to just give albuterol inhaler. We would want to give, IV or sub-Q epinephrine, because epinephrine is also a Beta2 agonist. Epinephrine can bind to alpha and Beta2 receptors. You can also give IV corticosteroids for inflammation. There's also an injectable form of Beta2 agonists. So when there is an attack, like I mentioned, if you have the drugs, you know what to do with them. But if they're not present, it's really difficult to reverse a bronchospasm. So a really good way to look at asthma is as how can we prevent it? How can we prevent people from having an attack, from using their rescue inhalers more than they need to? One of those ways is by giving an inhaled corticosteroid. You see one here. This is the Advair Discus, and this is an inhaled steroid which decreases all levels of inflammation. No corticosteroids have great side effects, but when we give them in a targeted manner, so directly to the lungs rather than systemically, we reduce the number of side effects. So this would be taken twice a day, by mouth, inhaled. Try not to get any in your mouth. Make sure the patient has a little bit of water or something afterwards to rinse the mouth out and decrease the chances of developing thrush, which is a yeast infection or yeast overgrowth in the mouth. But it works really well, and it's an adjunct therapy or a prophylactic therapy to prevent the overuse of the rescue medication. Another prophylactic daily medication that we can use aside or maybe in addition to corticosteroids is a drug called Singulair, which is a leukotriene inhibitor. It prevents the production of these pro-inflammatory proteins called leukotrienes, which are modified arachidonic acid, or from the arachidonic acid cascade, by this enzyme called lipoxygenase, or LOX for short. And the short story is that wherever leukotrienes are around, you get inflammation. So the way something like Singulair works, monoleucas sodium, it prevents the formation of leukotrienes, so then you get a reduction in pro-inflammatory proteins and an increase in anti-inflammatory proteins. This would be taken once a day by mouth. It's a pill, and it's a lot cheaper than this, but these can be used together or just one, and the whole point is to take something daily then to prevent the overuse of this. All right, lastly, in obstructive diseases, we have cystic fibrosis. Osis is development of, fibra is some sort of fibrotic change. This is an autosomal recessive disorder, and because of an abnormality in a chloride transporter, there is an increased viscosity of secretion. So mucus becomes very thick and then very hard to clear. It can lead to chronic respiratory infections, airway obstructions with shortness of breath, difficulty breathing. In this case, there can be a physical drainage of secretions, possible suctioning of secretions, because as we know, when mucus is allowed to stagnate, that's when it picks up deleterious bacteria and viruses and causes these infections. So there can be quite a bit of damage to the lungs by cystic fibrosis and the stagnation of mucus. The other thing that's actually in here that is a little bit more important to think about preventing, and it's not only that we don't want mucus plugs forming in the lungs and then possible, partial collapse like atelectasis or shortness of breath. One of the things that makes this really dangerous is the fact that we also have mucus plugs that can form in the pancreas. And one of the things that pancreas makes is trypsin, which is a protein that digests, or an enzyme that digests protein. And unfortunately, we are also made out of protein. So if a mucus plug forms and blocks the pancreas, then the pancreas traps or gets the trypsin trapped inside of it, and then the pancreas starts to be digested, which causes pancreatitis and really, really severe things as we go on. And because of only this trypsin, mainly, like trypsin is a really important thing in maintaining health of the body. As long as trypsin is allowed to flow out into the GI tract and digest food or other things that we've eaten, it's fine. But whenever trypsin gets stuck in the pancreas, it will digest the pancreas. And that's why you see disorders of the pancreas being really deadly. And there's not a long, there's not a great outcome with all of these disorders that are pancreas related, including pancreatic cancer, because of action of trypsin and what damage it can do to the organs. So cystic fibrosis, very thick mucus, very viscous mucus, and this is treated in typical ways to keep things like airways open, but also in very specific ways by giving medications to thin mucus, making it easier to cough up and less likely for the mucus to physically stick together and adhere.